Hello, my name is Rachel Burnett. In this presentation, I will be discussing malpractice cases involving advanced practice registered nurses. This presentation will examine two malpractice cases involving advanced practice providers. I will analyze each case using the four legal elements of malpractice, discuss the applicable standards of practice and scope of practice for APRNs, evaluate strategies that may have prevented malpractice, and conclude with my personal reflection on how these cases will influence my future practice as a family nurse practitioner. The first case involves a family nurse practitioner who cared for a patient with a positive fecal immunochemical test, or FIT, which is a screening test used to detect possible colorectal cancer. Although the abnormal result was available, appropriate follow-up was not completed and the patient was not referred for a timely colonoscopy. As a result, the patient's colorectal cancer progressed and was diagnosed at a much later stage. The patient ultimately died and the malpractice claim settled for more than $1 million. From the plaintiff's perspective, the central allegation was that the abnormal diagnostic result was not appropriately addressed. From the defense perspective, responsibility was shared among multiple providers and office systems, illustrating how communication failures and poor care coordination can contribute to patient harm. All four legal elements of malpractice were present in this case. First, duty was established because a provider-patient relationship existed, creating a legal obligation to provide care consistent with accepted standards. Second, there was a breach of duty because the abnormal screening result was not followed by appropriate diagnostic evaluation through colonoscopy. Third, causation was demonstrated because the delay in diagnosis allowed the patient's colorectal cancer to progress before treatment could begin. Finally, damages were substantial. The patient experienced advanced cancer, underwent more extensive treatment, and ultimately died. These significant injuries satisfied the damages element required for malpractice. The second case, which will serve as my primary analysis, involved a neurosurgery nurse practitioner caring for a patient with recurrent gliosarcoma in an inpatient setting following a craniectomy. During hospital admission, the nurse practitioner completed medication reconciliation and inadvertently continued temozolomide, a chemotherapy medication, at an inappropriate dosage. The supervising neurosurgeon also signed the medication orders without independently reviewing them. The medication error remained undetected until the patient's oncologist recognized that the patient had received a massive overdose. The overdose resulted in severe liver toxicity, bone marrow suppression, pulmonary complications, skin sloughing, prolonged hospitalization, and ultimately death. From the plaintiff's perspective, the nurse practitioner failed to independently verify a high-risk chemotherapy medication before continuing treatment. From the defense perspective, multiple providers participated in the patient's care, and system issues during medication reconciliation contributed to the error. Nevertheless, the providers retained responsibility for exercising independent clinical judgment. Again, all four elements of malpractice were clearly established. Duty existed because the nurse practitioner had accepted responsibility for the patient's care. A breach occurred when chemotherapy was continued without verifying the medication's indication, dosage, or schedule, and without consulting the oncology team. Causation was established because the medication overdose directly caused multiple life-threatening complications that significantly shortened the patient's life. Finally, damages included severe physical injury, prolonged hospitalization, loss of quality of life, and premature death. Together, these findings supported the malpractice claims and subsequent settlements. Several AA&P standards of practice were violated in this case. The standard related to comprehensive assessment was not fully met because the medication history was not adequately evaluated before treatment continued. Clinical decision-making and evidence-based practice were also violated because the nurse practitioner continued a specialized chemotherapy medication without confirming the appropriate regimen. The standards emphasizing collaboration and consultation were not met because no oncology consultation was obtained despite the complexity of the medication. Finally, the standard of promoting patient safety was violated because the failure to verify the medication directly contributed to preventable patient harm. This case illustrates that medication reconciliation is much more than documenting a medication list. It requires critical thinking, clinical judgment, and appropriate consultation whenever uncertainty exists. Under the Texas Nurse Practice Act, medication management and medication reconciliation fall within the professional scope of practice for an advanced practice registered nurse. APRNs are expected to evaluate medications, prescribe appropriately, monitor therapy, and collaborate with other providers when necessary. In this case, the nurse practitioner was legally authorized to perform medication reconciliation. Therefore, I believe the provider remained within the professional scope of practice. However, practicing within one's legal authority does not automatically mean the care meets the standard of practice or that the provider is acting within individual competency. This case highlights the important distinction between professional scope and individual scope of practice. Professional scope is determined by laws, regulations, certification, and licensure. Individual scope depends on a provider's education, experience, demonstrated competency, and clinical judgment. Although medication reconciliation was legally within the nurse practitioner's scope, independently managing a specialized oncology medication without sufficient expertise likely exceeded the provider's individual scope of competence. If this provider had extensive oncology experience or certification, the situation might have been different. However, when providers recognize limitations in their own knowledge, consultation becomes a professional responsibility rather than an indication of weakness. Two primary strategies could likely have prevented this malpractice case. First, every high alert medication should undergo independent verification before being continued. This indication This includes confirming the indication, dosage, treatment schedule, and appropriate laboratory monitoring. Second, consultation with specialists should occur whenever providers encounter medications outside their area of expertise. In this case, consultation with the patient's oncologist or oncology pharmacist would likely have identified the incorrect medication order before harm occurred. Both strategies represent proactive risk management and emphasize patient safety through collaboration. I believe several human and system factors contributed to this error. One factor was likely confirmation bias, in which providers assumed that medications listed in the medical record were already correct. Workflow pressures during hospital admission may also have encouraged providers to focus on efficiency rather than verification. Additionally, providers may have placed excessive confidence in the electronic medical record and assumed that previous medication orders had already been validated. Finally, the involvement of multiple providers may have created a diffusion of responsibility where each clinician assumed someone else had already reviewed the medication. This case demonstrates how small cognitive errors can combine with system failures to produce devastating outcomes. I agree with the legal outcome of this case because all four elements of malpractice were clearly established and the evidence demonstrated a significant deviation from accepted standards of care. However, I also believe this case reflects failure at multiple levels rather than the actions of one provider alone. The supervising physician, hospital systems, medication reconciliation process, and communication among providers all contributed to the patient's injury. Despite these system failures, advanced practice nurses remain individually accountable for exercising sound clinical judgment and recognizing when consultation is necessary. This case has had a significant impact on how I view my future role as a family nurse practitioner. One of the most important lessons I learned is that medication reconciliation is a clinical decision-making process rather than simply completing documentation. I also realized that asking questions and consulting specialists should be viewed as strengths that protect patients rather than signs of inadequate knowledge. As I begin APRN practice, I intend to verify unfamiliar medications independently, document my clinical reasoning carefully, and seek consultations whenever I encounter situations beyond my current expertise. This case reinforced that patient safety depends not only on medical knowledge, but also on humility, communication, and lifelong learning. Some general recommendations to avoid malpractice include always practicing within both your professional and individual scope of competence, independently verifying all high risk medications and diagnostic findings before making treatment decisions, consulting specialists whenever clinical uncertainty exists, maintaining thorough documentation that clearly reflects clinical reasoning, patient education, consultations, and follow up plans, and using evidence based practice and institutional safety systems. By consistently applying these principles, APRNs can improve patient outcomes while reducing legal risk. In conclusion, these malpractice cases demonstrate that patient harm often results from multiple small failures rather than a single catastrophic mistake. Advanced practice nurses have both the authority and the responsibility to exercise independent clinical judgment, collaborate appropriately, and recognize the limits of their own competency. Ultimately, practicing safely requires continuous learning, effective communication, and adherence to evidence based standards of care. By applying these principles consistently, APRNs can provide high quality patient care while minimizing the risk of negligence and malpractice. Thank you for listening.